All right, welcome. Today, we are diving into a really fascinating condition called diabetes insipidus, or DI. We're going to go from the tiny molecules that control your body's water balance all the way up to the practical, clinical tools you'll need to diagnose and manage it. This is your pragmatic guide. So let's just start with a sense of scale, because it's pretty mind-blowing. Your kidneys, they filter about 170 liters of fluid every single day. I mean, think about that. And out of all that, they manage to reabsorb over 99% of it, so you only excrete a liter or two. It's this incredible fine-tuned balancing act. And it's exactly this balance that gets completely thrown off in diabetes insipidus. So here's our game plan. We'll start with how the body is supposed to handle water. Then we'll look at what happens when it all goes wrong. After that, we'll walk through the clinical workup, learn how to read the test results, put together a solid treatment plan, and finally, we'll talk about what it's actually like to live with this condition.
Okay, first up, the basics. Before you can fix something that's broken, you have to understand how it works in the first place. And honestly, the system for water balance is beautifully simple. I like to think of it as a key and floodgate system.
It all starts up in the brain with a hormone called arginine vasopressin. You'll hear it called AVP. Your hypothalamus makes it, the posterior pituitary releases it, and its one job is to act as the key. It travels through the blood all the way down to the kidneys with a single crucial message: hold on to water. So when that AVP key gets to the kidney, it has to find the right lock. That lock is a special receptor on the kidney cells called the V2 receptor. When the key clicks into the lock, it sets off a chain reaction inside the cell. It's a classic signal cascade. It increases something called cyclic AMP, which in turn switches on protein kinase A. Think of it like a series of dominoes falling, leading to one final command.
And here's that final command. The signal tells these little water channels, called aquaporin 2, to get to work. These are our floodgates. They literally move up to the surface of the cell, open up, and allow water to rush out of the urine and back into the body where it belongs. It's how you make concentrated urine and stay hydrated. Simple, right? Key, lock, floodgates.
So what happens when that beautiful system fails? What if you lose the key? Or what if the lock is jammed? Well, that's when you get into clinical trouble. And it all starts with the main symptom, polyuria, which is just a fancy way of saying a massive amount of urination.
And that failure is called diabetes insipidus. The name itself tells you a lot. Diabetes means to pass through, and insipidus means tasteless or dilute. The floodgates just aren't opening, so water pours right out of the body. The clinical definition is pretty stark, making more than 50 milliliters of very dilute urine for every kilogram of your body weight every day.
Now, this is a super important distinction you have to make. The system can break in two main places. In central DI, the problem is in the brain. The hypothalamus or pituitary isn't making or sending out enough AVP. The key is missing. In nephrogenic DI, the brain is sending the key just fine, but the kidneys aren't listening. The lock is broken. So when you're thinking about why someone might have central DI, your differential should include anything that can damage that central key-making factory. Things like head trauma, brain surgery, tumors, or even infections like meningitis. Sometimes, sadly, even after a full workup, in about a quarter of cases, we just can't find a cause, and we call it idiopathic. For nephrogenic DI, we're looking downstream at the kidney itself. It can be, sure, but in adults, it's usually something we call acquired. And you need to have a few things on your radar. First and foremost, drugs, especially lithium. It's a classic cause. Lithium actually gets inside the kidney cells and messes up the signaling pathway, so those AQP2 floodgates never get the message to open. Metabolic problems like high calcium or low potassium can also do it. Okay, let's put on our clinical hats. A patient comes to you. They're thirsty all the time. They're constantly running to the bathroom. You need a system, right? A logical way to figure out what's going on. So let's walk through the diagnostic algorithm. First things first, you have to confirm they actually have polyuria. Are they really making a huge volume of urine? A 24-hour collection will tell you. Next, you check that urine. Is it dilute? If it is, you're on the right track. Then, you look at their blood. Because they're losing all this pure water, their blood should be getting more concentrated, so their sodium and osmolality will be high. If all these signs are pointing towards DI but you're still not sure, you move on to a more formal test. And that brings us to the classic old-school diagnostic challenge, the water deprivation test. You basically, under very careful supervision, stop the patient from drinking and watch to see if their body can figure out how to concentrate their urine on its own. It's the traditional way we've stressed the system to reveal where the fault lies.
Okay, this is where the rubber meets the road, interpreting the results. This is how you'll tell the difference between central DI, nephrogenic DI, and a tricky mimic called primary polydipsia, which is a behavioral issue where people just drink way too much water.
All right, let's break this table down because this is everything. In a normal person or someone with that primary polydipsia, if you stop them from drinking, their body will eventually kick in and start concentrating their urine. But in both types of DI, it won't. The urine stays dilute. So how do you tell them apart? You give a dose of desmopressin, a synthetic key. In central DI, you've just given them the key they were missing, so their kidneys respond beautifully and the urine concentrates. But in nephrogenic DI, you can give them all the keys in the world. The lock is still broken. Nothing happens.
Now, that water deprivation test works, but it can be a real pain to do, and it can even be risky for the patient. Thankfully, we have a better way now. Instead of indirectly testing the system, we can directly measure something called copeptin. AVP itself is really unstable in a blood sample, but copeptin is released right alongside it, and it's super stable. So it's a perfect stand-in or surrogate for what AVP is doing. And this new approach is a real game changer because it gives us clear, powerful cutoffs. If a patient's baseline copeptin is super low, well, that tells you the brain isn't sending the signal. That's central DI. If it's really high, it means the brain is screaming at the kidneys to save water, but they're not listening. That's nephrogenic DI. It's often much cleaner and more accurate than the old test. So you've nailed the diagnosis. Now what? The great thing is, once you know what's broken, the treatment is incredibly logical and targeted. Let's look at how we get these patients back in balance.
The treatment strategy flows right from the diagnosis. For central DI, it's simple. The key is missing, so you give them a replacement key, desmopressin. For nephrogenic DI, we have to be a bit more clever. We actually use a diuretic, a thiazide. I know, it sounds totally backward, right? But by making the body just a little bit volume depleted, it forces the early part of the kidney to grab more salt and water, leaving less to get to the broken part at the end. And for that lithium-induced DI, amiloride is fantastic because it can block lithium from getting into the cell in the first place.
Okay, we've gone deep into the science, but let's zoom out for a minute. It is so easy to get caught up in the lab values and the pathways, but we have to remember what this actually means for the person living with it. All those numbers we talked about, they translate into this: a thirst that is so profound and so constant, you can't ignore it. Having to get up over and over again every single night, which leads to just crushing fatigue. Your entire day revolves around knowing where the nearest bathroom is. It disrupts work, it disrupts relationships, it disrupts everything. This isn't just a water problem. It's a profound quality of life problem. So I want to leave you with this question. Getting the diagnosis and writing the prescription, that's just the start. That's the science part. The art of medicine is understanding the patient's experience and partnering with them to manage this thing day in and day out. Because our real goal isn't just to fix the numbers, it's to give them back a sense of control and normalcy in their lives.